Say hi and welcome to everybody. And I'm not going to say much of anything. I also would next like Melissa Bernstein to introduce herself.
Hi, everybody. Welcome. I'm so excited to see you all here. My name is Melissa Bernstein, and I'm the chair of the nutrition department here at Rosalind Franklin, and it's great to have you all here. And I know you're all really excited to hear Dr. Grega speak. So we'll allow Dr. Rowe to take a few minutes to welcome us all and introduce our tonight's activities and event.
Wonderful. Welcome, everyone. My name is Wendy Rowe. I'm the president and CEO of Rosalind Franklin University, and I'm very excited and honored to welcome you to this kickoff of our lifestyle medicine program and to also introduce our speaker. I'd like to first thank a few people. First and foremost, a big thank you to Doctors Andrea and David Feinberg, who are alums of our medical school, and I want to thank them for their generous support of the program. Thanks to Doctors Vitale, Damashki, and Bernstein for all the hard work that they've done getting this program approved by the state and by the accreditors. And thanks also goes to the Provost's office under Dr. Nancy Parsley and the Academic Affairs office under Vice President Dr. Maureen Caravan. So now I have the honor of introducing Dr. Meagan Grega. We're so pleased to have her kick off the program. She's the co-founder and chief medical officer of Kellen Foundation, a not-for-profit dedicated to making healthy choice the easy choice. Kellen provides school-based healthy lifestyle education and garden as the classroom program, supports access to nutrient-dense produce via the Eat Real Food mobile market and the Lehigh Valley Corner Store initiative, which engages participants in hands-on plant-based cooking classes in community centers and offers intensive therapeutic lifetime change intervention for both individuals and families. I think that's important. She's a graduate of Bucknell University with a BS in biochemistry, cell biology, and she got her medical degree, her MD degree from the University of Pennsylvania Medical School. Dr. Grega spent many years as a medical officer in the United States Navy, attaining the rank of lieutenant commander before resigning from active duty service. Thank you for your service, Dr. Grega. She's a member of the True Health Initiative Council of Directors and serves as a member of several national task forces dedicated to the expansion of evidence-based lifestyle medicine services. Dr. Grega is a member of the American Academy of Family Physicians, a fellow of the American College of Lifestyle Medicine, and is board certified in both family medicine and lifestyle medicine. Child and family health are both important to her, and the obesity pandemic in particular are issues in which Dr. Grega had a long-standing interest. She believes the benefits of regular exercise, adequate sleep, supportive social connections, healthy food choices, and the art of balance are the keys to improving our children's future as well as our own. And towards that end, she's committed to finding practical solutions that can be implemented by families and communities to strengthen each other physically, emotionally, and spiritually. So I'm so excited that you're here with us today, Dr. Grega. Thank you very much for coming to our kickoff.
Thank you so much, Dr. Rowe. And I really appreciate the invitation, and thank you guys for having me here so that we can talk about one of my favorite things, which is lifestyle medicine and how that can impact not only ourselves, but also our patients and our communities. So let me share my screen. Let's see how this goes. All right, I see Melissa saying I am good. So, all right, so today we are going to talk about discontent being the first necessity of progress and why lifestyle medicine is the missing piece of our healthcare toolkit. And Thomas Edison said many years ago, this discontent is the first necessity of progress. And I agree. I mean, like if you're pretty satisfied with the status quo, you are probably not going to be tinkering around the edges and come up with the next great breakthrough. But I am going to guess that probably the majority of you out in the audience tonight are somewhat discontented with the status of healthcare in our country at this point. So tonight, I'd like to share a little bit about how I became a discontented physician and also share a little bit about some of the steps that we can all take to help not only ourselves, but also our patients live longer and healthier lives. So this picture to me represents kind of the ideal of healthy aging, the way that we would all like to spend our later years, and not only having a long lifespan, but also having a long health span. So growing older with vigor and vitality, remaining independent and still connected to our friends and families, like living our life with purpose. So if this is our goal here in America, how are we doing with that? And to actually really delve into that topic, what I'd like to do is kind of look at the health of our country through the lens of my adult lifetime. So to be able to do that, we have to go all the way back to 1985. So this is 1985. This is me in 1985. I was 14 years old. And not only did I look very different back then, the health of our country looked very different back then. So this is when I was in high school, when the CDC started to report out on obesity maps for the country. And as you can see here, back in 1985, we're looking at just adult obesity rates at this point, but there was not a single state in the country that had an obesity rate of 15% or higher, not at all. So that was back when I was in high school. Let's jump ahead 10 years. This is when I was in medical school. So in 10 years, we made a big difference here. Now we've got about half of the country is in the dark blue, which is an obesity rate of 15 to 19%. So let's jump another 10 years. Now I'm a practicing family physician, and I am seeing the impact of these chronic diseases of hypertension and diabetes, heart disease every day in my practice. And you can see in that 20-year period, look at the difference on our obesity map here. I mean, now we've got some states that have an adult obesity rate greater than 30%, when back in 1985, we didn't have any that were any more than 15%. So let's go to 2010, which is when we got to the point where there was not a single state in our country that had an obesity rate of less than 20%. By now, we had already started Kellen Foundation because we realized that the impact of not only obesity, but all the other problems that kind of go along with that were just getting worse and worse and needed some new solutions. Now, after 2010, the CDC decided to change their colors in the way they look at their maps. So this map is going to look a little different, but this is 2019. And basically, it's worse. So every place in the country now, except for Colorado and DC, have an obesity rate of greater than 25%. Where I am in Pennsylvania and where you guys are in Illinois, we're at an adult obesity rate of greater than 30%. So we have made a massive change in just that amount of time. How did we go from, it took me to go from here over to here. How did our country go from here over to here? And, you know, some people say, like, is it genetics? Well, no, there's no way that our genetics have changed over the course of that period of time. What's really changed is our lifestyle habits. And it's not just about the obesity. There's a whole lot of other things that go along with these changes that have happened over the last, 40 years or so. So when you look at the top 10 causes of mortality in 2019, now, unfortunately, 2020 is going to be different because of the COVID-19 pandemic. But most years, these top 10 kind of shuffle around, but they're pretty much the same. So our top 10 killers are things like heart disease and cancer, COPD, stroke, Alzheimer's disease, diabetes, and kidney disease and suicide. Those 8 out of the 10 that I just mentioned are directly related to the lifestyle choices and behaviors that we have. And the economic implications of our lifestyle choices and then the resulting obesity and other chronic diseases are really pretty staggering. When you look at the fact that we are spending $316 billion every year treating cardiovascular disease, and even more, $327 billion for diabetes, you realize that, like, think of what we could be doing with all that money if we weren't spending it on basically treating the symptoms of these types of diseases. Our prescription medication costs are going through the roof, and the Federal Congressional Budget Office predicts that just Medicare and Medicaid, so not our whole healthcare system, not all of the insurers, but just Medicare and Medicaid will account for 20% of the GDP by 2050. So I would imagine most of you guys, I know I'm hoping to still be around in 2050. That is a whole lot of money that is going to be spent on basically putting Band-Aids on, not all, but about 80% of that is probably going to be spent on chronic disease care. And that's something that we could shift the paradigm as to where we are investing those resources. So where is that money going? At this point, a lot of it's going to medications. This just shows that back in 2015, as a country, we spent over $11 billion on long-acting insulin alone. Then we spent another $12 billion on the rosuvastatin and atorvastatin when you add them up together. So these are all medications that we are putting a lot of our patients on. And sometimes it's necessary. But there are other ways to potentially decrease these medications through the lifestyle changes that we're hoping to support our patients in making. So it's probably not surprising that the United States is the outlier here. You know, we're the ones that spend the most money per capita on healthcare when you compare us to our reference countries. And back actually in 2019, we spent over $11,500 per person in the United States for that year on healthcare. And unfortunately, it's not really healthcare. Most of it is actually really sick care. And it turns out to be about 17.7% of our GDP that we are spending. So what are we getting for all that money? Let's take a look. This is how we spend it. When we look at when we're spending that money, it's not in early childhood. It's not in early adulthood. We really make that jump right around age 50 to 60 when this is us. This is the US. And the money that we spend on healthcare skyrockets because that's when we really start to see the difference with chronic disease. So are we getting a good return on investment with all this money that we're spending? Sadly, no. This is us down here at the bottom. This is death from all causes per 100,000 people. So we are really down at the bottom, even though we are spending so much money. So how can we look differently at getting a better return on investment and having more health and less cost? So whenever I see numbers like that, it makes me just think, like, this is crazy. How is it possible that we are spending so much money and yet we're having some of the worst health outcomes in the developed world? And again, like we've said before, like, is it our genetics? But it can't possibly be our genetics that are that different from places like Canada and the UK. It's really coming down to the type of lifestyle choices that we're making and then what happens as the resulting disease. So in lifestyle medicine, we like to say that genetics load the guns. There's definitely a role of genetics in all of our health, but it's lifestyle that pulls the trigger. So if we can optimize our lifestyle choices, we're going to have a lot less of a chance of having those chronic diseases as we get older. So when we say the top 10 causes of mortality are these things, we name them things like heart disease and cancer, but what's really causing the problem are these things. This is a research study by Ali Makdad and his colleagues out at the Washington Institute of Health Metrics, and it looks at updating some classic research from back in 1990. It looks at like what really are the causes behind those death numbers? What are the root causes? And really, as you probably wouldn't be surprised, tobacco is number one, but poor diet and physical inactivity is number two. So, and then alcohol consumption. So all three of those factors are within our control as far as modifiable risk factors for death. And unfortunately, our life expectancy in the United States has pretty much stagnated and is now on the way down. So it had been for the past 60 years or so back in the 1990s, or I'm sorry, then in the 1900s, the rate of our life expectancy was on the way up. But then once we got to about 2014, we started to go down. And it's because of multiple different things. Definitely drug overdoses and the opioid epidemic had to do with that. But so did things like heart disease and diabetes complications in young and middle-aged adults. And so unfortunately, even though we spend the most amount of money, our life expectancy is suffering. And a lot of that has to do with, we have a lot of very good clinical care here. So it's not like we don't have good doctors and nurses and healthcare facilities, but unfortunately, your health outcome is really only impacted by the clinical care that you receive. That gives you about 20% of your total outcome. So the clinical care is the quality of our doctors and nurses in healthcare institutions. That gives us a 20% impact on our health outcomes. But the majority, the 80%, are things like our own health behaviors, the social and economic factors, and the impact of our physical environment, the built environment. So when we look at where we can make the most impact, how can we as healthcare providers make the most difference? We've got to get back out into these 80%, the health behaviors, the social and the economic factors, and the physical environment. We should definitely keep our clinical care way up there at the top, making that very, very important. But we have to impact these other factors as well, or we will not be very successful. And that is what lifestyle medicine is all about. So lifestyle medicine is the evidence-based, and that's a key piece, evidence-based practice of helping individuals and communities with comprehensive lifestyle changes. So that's things like your nutrition and your physical activity, stress management, social support, avoidance of toxic substances, to help prevent, and prevention is important, but also to treat and even reverse the progression of chronic diseases by looking at the root causes, not just treating the symptoms. How do we get down to the root cause? And there's 6 different pillars of lifestyle medicine. One has to do with healthy eating, and that's following a predominantly whole food, plant-based diet, not completely vegan, but to try to do a plant slant as much as possible, eating unprocessed whole fruits, vegetables, nuts and seeds, whole grains, beans, all the good stuff, spices, mushrooms. And then also paying attention to physical activity, trying to get at least that 150 minutes of moderate physical activity a week. More is always better, but any bit is better than none. So getting people up and moving, developing strategies to manage stress. So things like meditation, yoga. Stress management is different for everybody. So whatever is good for people to downshift and to be able to have that time of relaxation. Focusing on nurturing relationships, focusing on restorative sleep, prioritizing our sleep, and then avoidance of risky substances like tobacco and excessive alcohol. Now, luckily, there are places in the world that are doing this very well. These are the places called the blue zones. And blue zones are communities in the world where they have the longest lived population as a percentage of the population as a whole. So they're kind of like longevity hotspots. And there's one in Sardinia, Italy. There's one in Ikaria, Greece, Okinawa, Japan, and Costa Rica. There's actually one here in the United States. It's in Loma Linda, California. Now, it's not the whole part of Loma Linda, California. It's actually the Seventh-day Adventist community in Loma Linda. And when you look at what the blue zones have in common, it's not that they all have the same genetics or that they have the same type of water or that they're taking the same type of medications. It's that they have a very similar group of lifestyle habits that they follow. And they call these the Power 9. They kind of come in very similar to the 6 pillars of lifestyle medicine, but they have to do with how do we move, how do we eat, what's your stress management and social connection, that's the right outlook part, and the belonging, feeling like you have a sense of purpose and connection with your family. So how does that impact, for example, the Adventists in Loma Linda? Because they're here in America, so let's compare. How are we doing in America as a whole versus the blue zone of Loma Linda? So if we look at life expectancy, if you look down here for women and for men, this was from back in 2016, the purple is the United States population in general. So life expectancy back then was 81.2 years for women and 76.5 years for men. For me in Pennsylvania, we were doing a little bit worse. That's the yellow bar here. For you guys in Illinois, you were actually doing a little bit better. You're just a little bit more than the United States average. But since Loma Linda is in California, let's look at what was going on in California. So the blue bar here is the California numbers. So women, their life expectancy was 83.1 years. And for men over here is 78.6. But the Adventists, for women, it was 87.6 years. So they gained almost 4.5 years of life expectancy just by whatever sort of lifestyle habits they were doing. For men, it was 85.6 years. So that's like almost a 7-year jump in life expectancy. And if you take the Adventists and you narrow it down to just the ones who identify as vegetarian, they do even better. Women at 89.1 years and men at 87.6 years. So what they choose to eat and how they choose to live their life is making a big impact on their longevity. And this is kind of the type of food that we're talking about. This is a whole food plant-based diet here with lots of fruits and vegetables and whole grains, nuts and seeds. Doesn't mean that you wouldn't have any meat or dairy, but that would just be maybe a condiment in a way, or, on special occasions, not doing that, not eating that very often. Now, if you look at, unfortunately, the standard American diet, we flipped that nutrition wisdom on its head, and we do it the exact reverse. We have over 63% of our diet is processed junky foods, processed refined grains, sugars, oils, all that sort of stuff. 25% is from animal food. And only a very disappointingly inadequate amount is from plant food. 12% could even be considered plant food, but only 6% is whole plants. The other part is like apples and apple pie. I'm surprised they even count that, but apparently we have to figure out where we're getting our fruit from somewhere. So it's probably not surprising that our health outcomes are very different than people who are eating more in the blue zones tradition. And this is just a little bit more of information from the Adventist. This is the 2 Adventist cohorts that they've been following for many, many years, looking at their obesity rates as well as their type 2 diabetes prevalence. And just based on how they self-identify their diet, whether they consider themselves non-vegetarian, semi-vegetarian. So semi-vegetarian would be like, trying to cut down meat and dairy, kind of meatless Mondays. Pesco-vegetarian, still eating fish. And lacto-ovo-vegetarians or vegan, which would be more of what we think of as the whole food plant-based diet. You can see the stepwise decrease in their body mass index, depending on what type of diet they're eating. Same exact thing mirrored over here in their type 2 diabetes prevalence. And very interesting, even when you look at even their non-vegetarians, they still had a better diabetes prevalence than the American population as a whole. So could we change this? And I like this quote from Albert Einstein. And when I say, can we change this? The Adventists are doing fine. Like, can the rest of us change this? And I think this is a great way to think about that. Sometimes the easiest way to solve a problem is to stop participating in the problem. And unfortunately, a lot of what the problem is here is the lifestyle choices that we're making every day, and what we eat, the sleep that we get or the lack of it, how much exercise we get, how we're dealing with stress, and how much we feel connected and having a sense of purpose. So let's look at what we might be able to achieve if we make some of these changes. So this is kind of an unfortunate kind of like social population health history lesson that happened, but it's very instructive for us to see what happened. And I think this quote of those who cannot learn from history are doomed to repeat it. Unfortunately, we've been repeating this in the Western world for a while. This is a graph of cardiovascular deaths in Norway. And when you look, Norway had pretty much a standard American diet, not quite as junky as we have now because they didn't have processed foods back then, but lots of meat and eggs and cheese, some lots of sugar. And what you can see here is the heart disease deaths before, in the early 1900s. And it's kind of hanging around here. And then you get to about here in 1940, and the Nazis invaded Norway. And they took all their livestock and all the sugar and all the flour and like everything that they could send to the war effort. They took it away from Norway, and the Norwegians had to basically survive on what they could grow in their own gardens. And even though it was an incredibly stressful time, interestingly, their heart disease risk dropped significantly within a year. So it was not a long period of time, and it just dropped. And, as the war went on, it stayed low. And then all of a sudden in 1945, it goes back up again right after VE Day, right after they went back to eating the kind of diet that they were used to having before. And this wasn't really noticed a whole lot while it was happening, because obviously there was a lot of other things that people were worried about. But when you look back at this kind of unintentional population health experiment, you can see the impact that diet had on the heart disease deaths. More recently, Dr. Caldwell Esselstyn of the Cleveland Clinic has done some experiments or some research on patients who were considered that they did not have any kind of surgical or medical options left for their heart disease. They called them Essie's Walking Dead, because unfortunately they had been told, they didn't have any more veins to have another bypass, and they couldn't clean out with stents anymore. And these patients were basically told, go home, get your affairs in order. We'll try to keep you comfortable. Dr. Esselstyn said, well, this is interesting because I know that there's places in the world that do not have heart disease at the levels that we do, like Papua New Guinea and Africa. And he said, maybe it's the diet. So he decided to try feeding these patients a very low fat, very non-processed, high fiber, whole food plant-based diet. He didn't really do anything else as far as physical activity or stress management. Dr. Dean Ornish did, but Dr. Esselstyn pretty much looked at diet. And what he found was astonishing. So over here is a PET scan, and this is a patient before they started the nutritional therapy with Dr. Esselstyn. And you can see kind of down here at the bottom that the fact that it's dark means that there's very little blood flow in that area. So this was a person with angina, had chest pain, and obviously was having problems with blood flow to that portion of their heart. This is the same person, and look at how much improvement they've gotten. If I were with you guys, I would ask you to vote on how long do we think that took, but it actually only took 3 weeks. It took 3 weeks for that patient to go from this type of blood flow to this type of blood flow, with also a very significant decrease in their symptoms. Over here, this is actually an angiography. And this is a patient who has a very blocked left anterior descending artery. This is the same patient, but it was after 32 months of actually having that type of nutritional therapy of the very, very low fat, unprocessed diet, which just shows us that our bodies have the capacity to heal when we stop injuring them. And this all happened even before statins. This was back in the 90s. So these patients were not on statins. This is what a medical nutritional therapy can result in. This is a similar sort of situation, not actually showing you the objective things like PET scans and angiography, but this is Dr. Jenkins and his colleagues that looked at how much of a drop in LDL could we get with diet, and how does that compare with statins? Because this study happened after statins had become somewhat widespread. And you can see for people that had high cholesterol, the control diet was basically just being told, eat low fat, try to eat better, try to eat more fruits and vegetables, be low fat. So that's the yellow. The statin was lovastatin, it was 20 milligrams. That's the statin group. But the portfolio diet are the people who were told to really eat a high fiber, low fat, well, not even really all low fat, but definitely a very high fiber plant-based diet that removed things like meat and dairy and really looked at things like nuts for your fats and plant sterols, sticky fiber. What you can see is within 2 weeks, the drop in LDL was very similar between the statin and the dietary therapy. So we can get the same type of results with a dietary therapy that you could possibly get, at least with a low dose statin. So our patients that have side effects on statins or don't want to be on statins, there are other options that we can look at. All right, so diabetes is another one of our big ones. And a lot of times people, once they get the diagnosis of diabetes, they're kind of told up, it's going to be this way forever. You can, hopefully try and keep it under control. But what we saw even back in when this study was done, which was back in the late 70s, they took 20 men with type 2 diabetes. They were all on insulin therapy, and they admitted them to a metabolic ward where they could monitor them every day, make sure that the food that they were eating was very controlled, and they fed them a very high carb and high fiber diet. So it was basically a whole food plant-based diet that was weight maintaining. And that's the key, because we all know that if you lose weight with diabetes, a lot of times your blood sugar get better no matter how you lose the weight. But what they did with these gentlemen is they made sure that they did not lose any weight by weighing them every morning. And if they had lost weight from the day before, they were forced to eat even more food, more rice, more potatoes, more salad. So they managed to keep their weight at the same amount for the entire study, and they followed them for 16 days. And over that 16-day time period, the overall insulin requirements of the group of all 20 men decreased by 60%. And 11 of those men were able to stop their insulin entirely, even though they lost no weight and they had been on insulin for years. On top of that, their serum cholesterol dropped an average of almost 80 points. So this is what we think of as the power of plants. With our diabetics, we could make a huge difference as far as what their outcomes are based on giving them very intensive, therapy, especially with their diets. Something more recent is with Dr. Neil Barnard. He did a 74-week randomized control study. So that's cool, because the other one was not a randomized control study. It was just an observational cohort. But this was a randomized control study of diabetics that were living in the community. So they were not admitted to a hospital. No food was provided, but they did get a lot of very intensive counseling and frequent visits and follow-up. And what they looked at was the difference between a low-fat vegan diet or a whole food plant-based diet versus the typical American Diabetes Association diet. So, both of those diets are better than the standard American diet. But when you look at the actual results after 74 weeks, the people who were on the whole food plant-based diet lost more weight, had a bigger change in their hemoglobin A1C, their cholesterol dropped more, and their LDL dropped more. And this just shows the difference in the A1Cs. This is the whole food plant-based. So this is people living out in the community. And we see it with the diabetes prevention program too. So we see the same thing over and over again with the diabetes prevention program. These were adults that already had impaired glucose tolerance, but did not have the actual diagnosis of diabetes yet. And they were broken into 3 groups. The placebo group that was basically given standard care and told, try to lose weight, exercise more, eat better. The metformin group that were given 850 milligrams of metformin twice a day. So that's a pretty fair amount of metformin. And then the lifestyle group, who were really given a very intensive therapeutic therapeutic lifestyle change program, where they were, the goal was to lose at least 7% or more of their body weight. They were expected to try to exercise at least 150 minutes a week. There was a lot of visits, like 16 different visits with their health coach or dietitian or whoever was running the program. And what they found was amazing. The difference in progression to diabetes from being impaired glucose tolerance to a diagnosis of actual diabetes went down 31% from the placebo group to the metformin. So that's pretty good in and of itself. But the lifestyle group was almost twice as good, 58% decrease. And when they actually stopped the study early, it was supposed to be a 5-year study, and the results were so good at 4 years, they said it was kind of unethical to keep it going because the lifestyle group did so much better. But I would love for all of you guys to think out there, how many of us have the opportunity as healthcare providers to actually run diabetes prevention programs? Or how many of us can refer our patients? There's not that many of them out there, even though we know that this is a superior therapy for keeping people from developing diabetes. So how about cancer? Cancer is another one of our big ones. This is Dr. Dean Ornish, who has done a bunch of stuff for heart disease as well, but then he started to shift over into things like cancer and Alzheimer's disease. And he has a whole program that has to do with eating well, like what food you're eating, so low fat, whole food, plant-based diet, moving more, stressing less, so connection and stress management, and loving more. So that's the social connection piece. And he took 93 men who had prostate cancer, but early stage, I should say, prostate cancer that had already elected to defer the conventional treatment of like radiation or androgen blocking. And he randomized them to either the intensive therapeutic lifestyle change group, which is the eat well, move more, stress less, love more stuff, or just standard care, just watchful waiting and following them for a year. And what he found is after 1 year in the intensive lifestyle change group, none of the men needed to progress to conventional therapy, and their PSA levels decreased an average of 4%. But in the watchful waiting group, 6 of the men needed to go to progress to conventional treatment, and their PSA increased by 6%. At the same time, he took serum from the different participants and dripped it on prostate cancer cells in cell culture, and found that the men who were participating in the intensive therapeutic lifestyle change program, their serum was able to inhibit the growth of prostate cancer cells by almost 8 times more than the control group. And so that is some powerful cancer fighting serum that we got going on there based on the changes in their lifestyle. So then he continued to look a little bit more and said, okay, if we have these guys who, this was a new group, but 30 men that were had prostate cancer and were treated with the intensive therapeutic lifestyle change program, this time he just followed them for 3 months, and he used them as their own pre and post kind of, so that it wasn't randomized control, it was pre and post biopsy. But he looked at gene expression this time. And when looking at just over 3 months, he found that 48 genes were upregulated in the biopsy specimens and 453 genes were downregulated over just 3 months, which shows that our lifestyle choices are directly affecting the expression of our genes. And then I think the other really cool thing that he worked on with Dr. Elizabeth Blackburn, who then got the Nobel Prize, is this telomerase activity. So like the telomerase builds up our telomeres, which are the ends of our chromosomes, kind of like the little, like shoelace cap at the end of our chromosomes. And, it's not too far off to say that we are only as old as our telomeres. Like our longer telomeres means that we're going to live a longer time usually, and shorter telomeres means that we're, we're wearing out. And so what they found in this study is that after 3 months, the telomerase activity in the peripheral blood cells of the participants increased. So by doing this type of intensive therapeutic lifestyle change, they were actually repairing the ends of their chromosomes. And when you look globally, the risk factors for cancer are thought to be about 2/3 of our risk of cancer is from things that we can control, things like tobacco, diet and obesity, and sedentary lifestyles. Now, the Complete Health Improvement Program is another example of something that can be done as an intensive therapeutic lifestyle change program out in the community. This is Dr. Hans Diehl, who was the founder of the CHIP program. And there's been over 85,000 participants worldwide for the past 30 years, lots of scientific publications. But I wanted to point out this one because this is a return on investment type of one. And what they did at Vanderbilt University, this was an employee program where they took employees with type 2 diabetes and they had them go through the CHIP program during their work hours, which was great because it made it very convenient. They provided meals, and they found that over the course of the CHIP program, that about almost 62% of the participants decreased their hemoglobin A1C at 1 year. So even past the time that the CHIP program was done, because the CHIP program only went for about 8 weeks, almost a quarter were able to eliminate one or more medications. And that they found that because they were able to do this as they were self-insured employers, they found that they had a greater than 30% decrease in participant medical costs year over year that had gone through this program, which turned out to be a 1.38 to 1 return on investment within only 6 months from the amount of money that they spent on the program. So not only did it work, it was cost effective. And the Geisinger Fresh Food Pharmacy is another great example of something that shows amazing metrics that we should hopefully be able to expand throughout the country. So at the Fresh Food Pharmacy, they took patients with type 2 diabetes that have a hemoglobin A1C greater than or equal to 8, and also said yes to at least one of the food insecurity questions on the screener. And then they provided healthy ingredients for 10 meals per week, not just for the participants, but for the participants and the families. And they also had educational resources, lots of group classes, so lots of support, access to the multidisciplinary team. But what is most shocking to me about all this, like this is such a great program, but what is so shocking is the results that the hemoglobin A1C in the pilot participant patients decreased an average of 2.1 points. If we had a medication that came on the market that could do that, we'd be putting all of our diabetics on that medication. They had an 80% drop in healthcare costs, and they had a 40% decrease in the risk of death and serious complication. So again, if this was a medication, we would be putting almost all of our diabetics on it. We could do the same thing with food and the support of an intensive therapeutic lifestyle team around these patients. And this is just an example of a community-wide intervention. This is Albert Lea, Minnesota, that signed up to be a Blue Zones community. And they're a population of about 9,000 people, so pretty tiny, but still, what they were able to do is change the choice architecture and the social norms of their community. So they improved the infrastructure for walkable and bikeable transportation. They changed the food environment by having restaurants offering at least 3 plant-based entrees and changing their default side option to fruit instead of fries. You could still get fries or chips, but you had to ask for it. The schools stopped using candy for fundraisers and using snacks as a reward. And 25% of the citizens signed a healthy lifestyle pledge. After 18 months, the residents of Albert Lea lost 7,280 pounds over the course of all of them and saw a 40% decrease in healthcare costs, as well as a 3.2 years of increased life expectancy based on their changes of their biometrics. I mean, that is amazing. So it just goes to show lifestyle habits are contagious. And the more that we can do as communities, the more effective we're going to be. And also just to kind of wrap up, like what's going on with lifestyle habits, this is one of my favorite studies, which is, it's called Healthy Living is the Best Revenge. And what it looked at was 23,000 participants, middle age, followed them up for almost 8 years, and they evaluated 4 lifestyle factors. One was their BMI less than 30. So were the participants at least not obese? Did they smoke? So no tobacco use. Were they physically active? And it was only 3.5 hours a week. So it was not like going out and running marathons or doing a Tough Mudder or something. It was like, do you get up and move around at least 30 minutes a day, basically? And did they follow a diet that was predominantly fruits and vegetables and whole grains and was low in red meat consumption? So it was not a vegetarian or vegan diet, but it was definitely a plant slant. And what they found was if you followed all 4 healthy lifestyle factors, you had an almost 80% decreased risk of developing any chronic disease during the course of this study. I mean, there is no medication or procedure that we have access to that we can use for our patients that have that type of result. So when we look at that and say, this is great, okay, so this is kind of the answer to our chronic disease epidemic, how many Americans actually follow and can say that they have all 4 of those lifestyle habits? So I want you guys to like think in your mind, pick a number. How many? It is 2.7% based on NHANES data. So only 2.7% of American adults could demonstrate all 4 healthy lifestyle characteristics. So no wonder we are not doing so well as far as our heart disease and our diabetes and hypertension and stroke. The American Heart Association also has something similar. It's called the Simple 7. And they have demonstrated that if you get at least 5 of these, you can decrease your risk of heart disease like in half. But if you get all of them, I mean, you make a really big difference. They are no tobacco use, eating a healthy diet, physical activity, maintaining a healthy body weight, managing your blood pressure, controlling your cholesterol, and reducing your blood sugar. So very similar, just to have some more biometrics, actual objective measurements in there. but only 1% of Americans have ideal numbers for all 7 of the simple 7. So we obviously have a lot of work to do. It makes me go like that as a doctor because it really makes me feel like we have so much potential to change this for the better, but we have to flip the system around because we know that our pills and our procedures are helpful. They can slow down the trajectory of chronic disease. They can improve things, but they are obviously not sufficient to restore the amount of wellness and health that we're looking for. So I always say that regarding healthy lifestyles, there's no lack of information. I mean, the research is out there. The evidence-based stuff is in the journals. There is a lack of implementation. So that is going to be the challenge of our generation is how do we implement it? We kind of stand on the shoulders of giants who did the research and showed us the facts. But now how do we go out and actually do this in our communities? And it is becoming more and more imperative. It is critical that we do. Because if you look at what happened with the COVID-19 pandemic and you look at the risk for severe outcomes, this study that was done recently in the Journal of American Heart Association showed that obesity, hypertension, diabetes, and heart failure accounted for almost 2/3, so 63.5% of the attributable risk for hospitalization. So if you came in contact with SARS-CoV-2, you could have a very wide range of outcomes. You could be asymptomatic, you could be mildly symptomatic, and you could go all the way to hospitalization, ICU, thromboembolic events, or death. What was the difference for people? And a big part of the difference are some modifiable diseases that we could work on. Now, age is a non-modifiable risk factor, and that definitely played a role. But when you look at the fact that obesity accounted for the highest attributable risk, 30.2%, and even more worrisome to me is that risk was similar for all age groups, whether you were 18 or whether you were 65 plus. So obesity made a big impact as far as your risk of severe disease. And then racial and socio-demographic factors also play a role. So Black and Hispanic patients, unfortunately, had the highest proportion of COVID-19 hospitalizations attributable to these cardiometabolic diseases that we know we can prevent and treat and hopefully reverse with lifestyle changes. So I wanted to leave us at the end here for us to all think about what type of healthcare provider do we want to be? And what this picture or this cartoon represents is all that water on the floor. That's the mess of all the chronic diseases and the things that we see almost every day as practicing physicians or other healthcare providers. We come in and there's a lot of mess on the floor because there's a lot of chronic disease that we're trying to work on. And we can either choose to do what we're doing now, which is spend a lot of money on mops and like upgrade our mops and then like get mop extenders to try to be able to clean up more mess. Or we could really look at what's causing the problem and look at turning off the faucet. So Thomas Edison, I started with a Thomas Edison quote, and I'm going to end with a Thomas Edison quote, which is Thomas Edison said, "The doctor of the future will give no medicine, but will interest her or his patients in the care of the human frame, in a proper diet, and in the cause and prevention of disease." Now, I would not say that we are there yet, but I feel like Thomas Edison was kind of sort of channeling lifestyle medicine all the way back then. And that is where I feel the future of healthcare is going to go, is with looking at how do we help people stay healthy? And if they already have chronic disease, how do we restore them to a more resilient state of health? So these are just a couple of additional resources that I think are helpful when you're looking into lifestyle medicine stuff. Dr. Grega is my favorite, and his How Not to Die book was one of the best things that I read as I started on this journey. Proteinaholic by Garth Davis, who is actually a bariatric surgeon, believe it or not. That's an interesting one. Blue Zones by Dan Buttner is great. And Salt, Sugar, Fat is by Michael Moss, who is not a doctor. He is actually like an investigative reporter, but it really goes into how our food system, and especially big food, has been able to manipulate the food that we eat so that we keep coming back for more, even though it's not healthy for us. Here's some videos, and I definitely would recommend the nutritionfacts.org website. And with that, I think we are ready for questions. So I'm going to stop sharing my screen and see what sort of things have shown up in the chat. What do we got?
So if you have
Jeff,
any
was
questions.
there anything that showed up? Any questions for anybody?
There's nothing there right now, but I did get a question by email, so I'm going to ask you that. Is that okay?
Absolutely, yeah.
Okay, so the question was, I have friends and family members who are obese or overweight and who struggle with chronic health issues. but their physicians almost never, all in capital letters, discuss nutrition or offer guidance or encouragement on healthy lifestyle choices. One of the friends told them that they told me losing weight would help. So that's all they said was you should lose weight. I know that may change with better prepared future physicians, but what can be done to remedy this current systemic failure on this front?
So that's a multi-part answer, but an excellent question. So as far as remedying it, I agree. Unfortunately, most physicians of my age and older were not taught any of this in medical school. It's not something that's part of our culture. That's part of what lifestyle medicine and the board certification is trying to change. So now we're really trying to focus on medical schools. So for example, I teach in the Temple Lewis Katz School of Medicine medical school. And I have to say medical students are very interested in this sort of information. We're really working on residents as well. So the lifestyle medicine residency curriculum through the American College of Lifestyle Medicine is starting to percolate out. I believe there are 17 hospitals in the country that have residencies that are implementing that, and there'll hopefully be more and more every year. So these docs will be trained on it. But in the interim, you can find doctors that are trained and believe in this type of therapy by looking at like there's some that are telehealth doctors, like plant-based telehealth is one that's out there. There's websites that are like plant-based docs that you can find information about doctors that might be in your area. The American College of Lifestyle Medicine has a directory that has doctors that are certified in lifestyle medicine and dietitians and health coaches and, all of the different wraparound sort of like team that we need. So you could find somebody hopefully in your area or through telehealth that could help. But I also think that reading the books can be very helpful too. So Dr. Grega has a How Not to Diet book, and it kind of goes through a lot of this kind of evidence-based stuff that you might be able to implement on your own. It's also really helpful to have a supportive community. So if there's other people in your neighborhood, in your religious institution, in your Facebook group, whoever that you can reach out to that want to go on the journey with you, it's a lot more likely that you'll be successful. So I agree. And thank you for pointing out, this is one of the things that the medical profession needs to work on, is we need to help train the physicians, the dietitians, the health coaches, and all the other providers of the future, that this is the kind of foundation of healthcare.
Thank you. So there was a question about protein and related to plant-based diets. So can individuals get enough protein if they're on a plant-based diet or even a vegan diet?
Absolutely. I love that question. And I didn't put in my slide on that, but that's a very good one. So truly in the United States in general, if we are eating enough calories from a diverse array of foods, we are not going to be protein deficient. And what I mean by that is that if you look at NHANES data, the recommended daily allowance for women is about 46 grams of protein, and it's basically 0.8 grams per kilogram. For men, it's about 56, 58. So you can figure it out for the individual. But when you look at what we're actually eating, women are eating on average over 70 grams of protein, and men are eating over 100 grams of protein. So when you look at, can you get enough protein from a plant-based or a vegan diet? My residents asked me this too, one of my family medicine residents. And so I went through my day and looked at, okay, what am I actually eating and how much protein? So somebody like me needs about 40 some grams of protein a day. And I had oatmeal for breakfast with some walnuts and some raisins. I had for lunch a edamame salad with some, I think I had something that was like a quinoa based like power bowl. And then for dinner, I'd had like a butternut squash roasted apple soup and some red potatoes and some asparagus. So like I worked it all out, and then I put it into my nutrition calculator, and I ended up with, I had not had any meat or dairy that whole day, and I had almost 60 grams of protein. So as long as you're eating whole foods and you're putting in the nuts and the beans and the quinoa and the, like the chickpea pasta, stuff like that, you can definitely get enough protein. The issue really, I think, in our society is that we don't get enough fiber. We worry about protein and we're like, oh, I'm not gonna get enough protein. But what we really don't get is enough fiber. Americans average about 15 grams of fiber a day when we should be getting more, depending on if you're a woman or a man, up in the upper 20s or up into the 30s grams of fiber. So it's really no wonder that we are a nation of constipation and diverticulosis, unfortunately. And I saw a study recently that shows that we spend hundreds of millions of dollars every year on stool softeners and laxatives, which, could you imagine if we use that money for like lentils and berries? We would be in so much better health, and we would definitely be able to decrease our issues with constipation. So yes, you can get enough protein on a plant-based diet, but you have to be careful to eat a variety of foods and not eat like, I used to be the director of women's health services at a college. And so I saw a lot of women who were vegan for many reasons, understandably, but what they thought of as vegan was Coca-Cola and French fries and white bagels. And so for them, they weren't getting the type of healthy nutrition that they need. So just taking out, I love the words whole food, plant-based, because vegan says what you aren't eating, whereas whole food, plant-based says what you are eating. And if you're eating the variety of whole grains and nuts and beans and all that good stuff like I was talking about, even spinach has a lot of protein in it, you will get the protein that you need.
Thank you. So the next question I have is, discussing weight can be a sensitive topic when talking with patients. So what is the best approach to talk to patients about their weight?
That's a very good question. And I absolutely agree that it is one of those very touchy subjects. And the key is to have the relationship with the patient. And so if it's the very first time that you're meeting, that might not be the best time to approach it, though it still would be something that I would bring up through the entire discussion of saying something like, how do you feel about your weight? Or have you thought at all about your weight? Something like that. But as you get to know people and you have that relationship, it's good to ask their permission and say, I'd really like to talk to you about how things are going with your weight. Would that be okay? And actually over the pandemic, we've seen a higher number of people who are like, no, I don't want to talk about it right now. Like I have enough other stuff going on. I don't want to deal with it. And we say, okay, cool. So could we talk about your exercise? Or could we maybe talk about your sleep? Like pick another pillar to work on. But when you ask for permission, say there's some things I'm concerned about, I'd really like to share them with you. Would that be okay? Then it gives them the opportunity to be like, nope, I don't want to deal with this today. Or to be like, yeah, let's talk about it. And then you can start focusing not on the piece about how anybody looks, because that obviously is not what we're worried about in any way. It's how it may affect their health and trying to find out what is important to the patient. So like, what sort of activities do they want to continue doing? What do they want to be around for to see in the future? And then tie that to the fact that depending on what their weight is, they may have a decreased chance of being able to participate in those things in the future. The other thing I think is really just trying to give for example, if they say no and say, then back off. If they say, no, I don't want to talk about this, back off and say, that's totally fine. And just know that when you're ready to talk about it, I'll be here for you and I'd love to talk about it. And so just sort of like inch your way, I think is a good way to put it.
Great. There's a lot of nutrition questions. So the question is, what do you think of the paleo diets? Are you familiar with Dr. Wall's high-fat keto diet approach that allowed her to recover from multiple sclerosis? And she uses this approach to also treat patients.
So I think that anytime you get rid of a lot of the junk of the standard American diet, so the processed foods, the sugary sweetened beverages, that you'll get an improvement. And paleo does that. Like paleo does a lot of things right from the standpoint of getting rid of the processed carbs and the extra added sugars and those sorts of things. I feel like that the overwhelming observational cohort data, when you look at the longest lived populations in the world, they are eating plants. They are eating a lot of, and they're eating whole grains, not always like wheat, but they're eating whatever version is native to their area. And they're eating a lot of fruits and vegetables. They're eating, I know paleo, you can do nuts and seeds, so that's okay. But the other thing that worries me about paleo is how meat heavy it is. And depending on what type of meat you're eating, we know that processed red meat is a class 1 carcinogen for colon cancer. and that just regular red meat is considered a class 2A, I believe, which is a likely carcinogen for not only colon cancer, but pancreatic cancer and I believe prostate cancer as well. So I feel like there's a lot of things with the paleo diet that are good, but that a focus on things like meat and obviously there's no dairy in paleo. So that helps from the whole prostate cancer standpoint. But if you are focusing on meat, where are you going to get your like kind of your phytonutrients and your fiber and that kind of thing? Now, I do know some people that are able to pull off a pretty healthy paleo diet, and they are really focusing on unprocessed vegetables, lean, like people that are hunters, they go out and they, get deer and that kind of thing. But I also know people that are paleo, people that are eating like paleo power bars. And so that is a very different type of food choice. So my goal for patients is for them to eat what they will be able to continue eating. I don't want them to starve themselves. I don't want them to feel deprived, but to shift as much as possible to unprocessed foods, and as much as definitely like the power things like the greens and the berries and those types of fruits and vegetables are really, really important. As far as the high fat keto, I don't know that particular person that was mentioned, but I do know that there are downsides to the keto diet from the standpoint of like your body's functioning. So some people have done a very good, and when I say that, it has to do with like the brain fog and the constipation and like the stuff that goes along often with cutting out fiber and cutting out the phytonutrients. Now, again, from the multiple sclerosis standpoint, if that person was cutting out a lot of sugar and was cutting out a lot of processed junk, that was probably a really helpful dietary move from where they were before. And maybe that's what they needed to help heal from the multiple sclerosis. Dr. Sarai Stancic, who does the Code Blue movie, she didn't do the same thing. She recovered from multiple sclerosis with a whole food plant-based diet that was really focused on blueberries and whole grains and lots of greens and everything. So I feel like there are multiple paths to the same mountaintop. And one of the most important thing is that we get rid of a lot of the processed junk that we currently are eating and high sugary sweetened beverages, processed meats. My feeling is that it is easier to be satiated and feel full and satisfied on a whole food plant-based diet because the caloric density is lower. So you get a higher volume of food, you feel full. It's easier to stay kind of like in your healthy calorie requirements. But I do feel there's a lot of research that could still be done to try to tease out a lot of these things. And when we talk about lifestyle medicine, the nutrition is always the one that really seems to be where there's the most debate. And I feel like we should also be focusing on the other 5 pillars. But when we come to the nutrition debate, I think more unites us than divides us. And what unites us is try to get off of the sugar, try to make sure that you're eating as much whole foods as possible. Don't neglect your veggies. And if you just get that far, you're doing really good.
Thank you. Okay, so there was one related to the study. So to the studies. So and they apologize if you had mentioned this, but is there a number of people or patients that were able to keep up with many of these lifestyle changes after these studies have been concluded?
So it depends on which study we're talking about. Dr. Esselstyn's study had about 72% of the patients were able to keep up after 12 years. So even after 12 years later, they still were following it. Some of Dean Ornish's study, it depends on which one we're talking about, but he also has shown pretty good adherence. And if you look at, actually, I do have these slides here. Wait, hold on. Let me share my screen again. Let's see. Go to the very end because I wasn't sure if I would have time for this. Let's see. All right, can you guys see? Oop, that didn't work. Let's do this one. Can you guys see my screen? Can you see it? Okay. So this is medication adherence after an MI in the community. So these were people who just had their heart attack and they were sent home on their statin and their beta blocker and their ACE or their ARB, as they should be after they just had their heart attack. And when you look at 18 months later, 30% of the patients have stopped taking their medications. So only 70% of patients are still taking the pills that we prescribe after something as serious as a heart attack. So how does that compare to the lifestyle modifications, which is what you're kind of talking about, is like, can you maintain these types of lifestyle changes? So this is behavioral adherence with a lifestyle medicine intervention. And this showed that after 18 months, participants who had engaged in the beginning, 63% of them were still increasing or maintaining their increased physical activity. 75% of them had decreased the amount of calories that they were consuming. About 60% of them were increasing their vegetables still. 83% were still at the lower fat intake. A bunch of them had more fiber, and a lot of them had decreased their sweets. So I think what this kind of goes to show is we think that when we give people medications that they're going to keep taking them. And unfortunately, a lot of times that's not the case. And we think that if we tell people to change their lifestyle, that they're not going to do it. And that's actually not the case either. However, it is more likely that people will maintain these lifestyle changes if they continue to stay in a supportive therapeutic relationship, that they continue to connect. So like, for example, the CHIP program that I showed you with Dr. Hans Deal, they have an alumni program where like some places it's monthly, some places it's quarterly, but people get back together, not for specific education, but like for check-ins. And that definitely makes it more sustainable. So when we think about lifestyle change programs, I like to think about it in relationship to therapeutic dose. So in the same way that if somebody came into the ER and their pulse ox was like, 80%, and they had terrible community acquired pneumonia and they were, hypoxic, you could, if you took 10 milligrams of penicillin and like rubbed it on their skin, they wouldn't get better. But it's not because penicillin is not good for pneumonia. Penicillin is good for pneumonia, but you didn't give enough of it. You didn't give it the right way. You didn't do it long enough, like that sort of thing. Same thing for lifestyle change programs. If you just have like a health fair or you give a handout once, that usually is not very effective. But if you do an intensive therapeutic lifestyle change program where you're meeting weekly or twice a week or sometimes every other week, and you do it for a chunk of time, some programs are 12 weeks, some are 18 weeks, and you continue then to follow up with the patients, help them form a supportive group where they're kind of supporting each other, there's a lot of good adherence data that works. All right. What other questions do we have?
Great,
You're
thank
welcome.
You. Okay, so do we have time for one more?
I'm good. I don't know about you guys.
Okay, so there was a couple questions related to how do we approach the subject of healthy diet or healthy eating patterns and lifestyle with proper cultural focus.
Mm-hmm. I love that one. That's a big thing that we do with Kellen Foundation, or when I say we do, we try to focus on, because it's difficult. Like, so in our area of the Lehigh Valley, we have a large Hispanic population, a large Syrian population. We've got a lot of different Asian types of populations. So very different culinary history. And the best way that I have found to approach it is kind of through the Blue Zones lens of saying that all these different places in the world have different cuisines. It's not like you have to eat what I think of as my whole food plant-based diet, but every place in the world is kind of, that's a Blue Zone, is following the same concept of basically whole, fresh, unprocessed fruits, vegetables, grains, nuts, and seeds, beans, as much as possible. So if it is, what I like to do is ask patients for their favorite recipes, and then we try to make them healthier, kind of tweak them. So there's lots of really healthy options if you tweak the recipes in Hispanic cuisine. Absolutely, they've got a ton of beans, they've got a ton of onions, and if you throw some more grains in, a lot of the Indian cuisines have a lot of really good stuff with curries and spices. So I try to engage the patient or the family, because a lot of what we do is out in the community on the mobile market, and say, what do you like to eat? And then find out what that recipe is, and then look at ways that we can make it healthier, either by adding in more fruits and vegetables and taking out some of the processed stuff, or doing some things with different types of fats instead of putting lard or butter, using avocado or cashews or something like that. But I think the key piece to all of that is you got to have conversations with the patients and the families and find out what they're eating now before you try to change them to a different diet.
Thank you very much. Okay, and so there was a question about this being available following, so this will be available. We are recording it, and we will make sure that that link will get out to people who have attended, and we'll also get it out on some other formats also. So I do have, so how do you ensure, we'll do one more, how about that? Is that good? Okay, how do you ensure you get enough essential fatty acids?
Oh, essential fatty acids. Okay, so that's a tougher one. So as so we got our omega-3s and our omega-6s, and as far as our essential fatty acids, and our omega-6s are ubiquitous throughout the diet. So all of our diets pretty much. So we don't usually worry about not getting enough omega-6s. But the ratio to omega-6s and omega-3s is often off, or not optimal. Like we'd want that ratio to be 1-to-1 or 4-to-1. And in the United States diet, it's usually more like 10-to-1 or 20-to-1. So that's kind of pro-inflammatory. So there are places that you can get omega-3s. You can get it from walnuts and chia seeds, and I have my whole list of it. I think Brussels sprouts. So I have a whole list of foods that we give patients to say, use this for your omega-3s. It's obviously something you can get from fish, but the problem with fish, unfortunately, is that we have polluted the world they live in. And so fish often have high mercury contents or high persistent organic pollutants, especially the higher up on the food chain those fish are. So I prefer, and what I personally do is I take an algae-based omega-3, well, it's like DHA and ALA supplement, because it's so important for our brain health. I don't want to mess with my brain, and I don't know if I'm going to get enough chia seeds or flax seeds or whatever that day. So I do try to eat foods, like I put walnuts on my breakfast every morning, but I don't know if I'm going to get enough omega-3. So I take an algae supplement, and that's what I recommend for patients, unless they're going to be really, really vigilant about making sure they get enough of those types of plant-based foods. For people that like fish, I tell them eat as low on the food chain as possible. So sardines, little thing, because they will have less of the neurotoxins that have accumulated in things like tuna and some of the higher fish. Ooh. Well, before we end, I just want to say thank you guys so much. And I want you to all go out and become lifestyle medicine warriors and change the world. And I am really, really glad that this program is starting at Rosalind Franklin, because I think we need an army of us out there to change the culture.
For sure. Or a navy of us.
Or a navy. I would like that. Yeah, that would be good. That's right.
All right. Well, thank you. Thank you, everybody, for joining. And thank you, Dr. Grega. It was excellent. Thank you so much for your time.